majority of the kids in your program, then going to therapy, then by gosh, we're going to fund enrolling them in music class and dance class rather than enrolling them in mental health therapy, rather than because compliance for compliance sake. So that would be my rationale.
So I felt like the question might have been rhetorical to the federal partners. It was for them to provide feedback to us, which was outstanding. I mean, I think in general, my approach, like I said, is I want the right data at the right time to make data-informed decisions and allow rapid cycle innovation as opposed to narrative-driven, compliance-driven paperwork and expensive, busy work. So hopefully the totality of actions that you see from ACF aligns with that. I'd be remiss if I didn't close by talking about a little bit of what I did this morning when I said where a child is placed matters and stability of where they're placed matters. So we're running our Home for Every Child campaign where we're trying to get states to commit to increasing their ratio of foster homes relative to the number of foster kids. Why that's important is it gives states two focuses. First is they can recruit more family-based homes and kinship homes, which offer more stable, nurturing environment than group homes or Airbnbs and short-term rentals. Most importantly, states can reduce the entries into foster care by having effective preventions, preventive services, family preservation services, and you'll get more bang for your buck investing in prevention rather than just trying to recruit your way out of this. To date, 17 states have joined on to the Home for Every Child campaign. When they do so, they get record paperwork relief from us. We get monthly data to make data-informed decisions. So far, those 17 states are heavily concentrated in the SEC, but we are quickly moving to the Mountain West and Big Ten. This week, we'll be announcing 2 more states that have joined that effort. But if your state has not joined, a very easy conversation for you all to have when you get back is, why not?
Yes.
So, thank you.
I'm going to the regulatory burden. I think that we really need to focus on what we're requiring the clinicians to do and whether that actually benefits the care at the bedside. One of the strong beliefs I had in giving up my private medicine career was to be out here to come implement change where I could have better, what we can do. I think the fabric of where we come from in the government at the state, federal, local level is how does this make care better at the bedside between the doctor and the patient, between the nurse and the patient, the psychiatrist and the patient, and so that informs, that should inform our every decision. And getting rid of the regulatory burden, and that's what SAMHSA has been looking at. Looking at outcomes, not just providing programs. Checking the box. Okay, there's a program for treatment that's out there. They're looking at best practices. I think that's where SAMHSA can lead. But the federal government and the state government, that's only the top layer down. And what's really heartening to me, for me to see here, is the cultural change that I saw that was needed to change opioid prescribing practices wasn't from the CDC saying this is how you prescribe better. It was from an awareness within the medical community and within the community at large that there's a problem and we needed to make sure that we were prescribing appropriately. And so that's, I think, that the key decision point.
Thank you so much. I just want to say, Assistant Secretary Adams and Dr. Westlake, we're really grateful for coming to the table and having these conversations. And it is pretty rare to be able to have an opportunity to bring state advocates and practitioners and people who are making decisions at the level that you are to the same table with this kind of responsiveness. And I'm grateful for your openness and also for your leadership in these ways. Thank you so much. And I want to thank you, Sam, and thank you, Dr. Kalibi, and thank you, Amy, for all being a part of this panel and part of the day. And so let's continue the conversation.
We're ready.
Great. Okay. Thank you.
Good to meet you. Thank you. Great job. Thank you.
Oh,
If everyone can please take your seats, we're going to start our last panel here as soon as possible. Please take your seats. Test one.
Microphones here and there. Any seat you want.
All right, thank you, everyone. I'm Justin Santapietro with the MAHA Institute. I'll be moderating this panel along with my colleague David Cohen, who you heard from earlier. I'd like to get started with our last panel of the day here entitled Federal Reform, a Coordinated Path Forward. As a quick housekeeping note, we are going to reserve some time at the end for audience questions. So if you'd like to submit a question for us, please write it down on some of the notepads we have here, and some of our MAHA Institute and ICI colleagues will pick those up and bring them up to us for the last 15 minutes, but we do have a very hard stop to prepare for our final speaker of the day. We're very excited to have with us today a whole group of folks representing HHS across the board, and at the MAHA Institute, one of the things that we really prioritize is trying to be that nexus between the MAHA advocates on the ground, our grassroots, our clinicians, practitioners, advocates, and the policymakers at the state and federal level. So I just want to reiterate what Deborah said earlier, that we're very grateful for your presence here today. Thank you for making yourselves available, interacting with the public, listening to some of these incredible stories we heard today. I think this is an excellent path forward for government in general and rebuilding the relationship that's necessary between the public and the government, especially on these health issues which are so deeply personal and relevant to our lives. So about a year ago, HHS released, the administration released the MAHA strategy report, and that directed, among many things, HHS to form a cross-agency working group. And it was tasked with, quote, evaluating prescription patterns for selective serotonin reuptake inhibitors, antipsychotics, mood stabilizers, stimulants, and other relevant drugs for children. HHS will also evaluate the therapeutic harms and benefits of current diagnostic thresholds, over-prescription trends, and evidence-based solutions that can be scaled up to improve mental health, including through school-based interventions, diet, and foster care service. So that's a pretty big challenge. So to kick us off, I'd like to ask each of you, first of all, to just introduce yourselves, give us a brief overview of the overarching mandate of your agencies, and the role that each of you play in your agency's implementation of this element of the MAHA strategy report.
Thank you, Justin. Can you hear me okay? So the SAMHSA, I think, leading the behavioral health, substance abuse, mental health treatment for the federal government. I'm fairly new coming into this role. Like I know probably most of the people at the last panel. It's my third week here, but I have a deep background in state opioid policy reform experience, and came up with the fentanyl-related substance class scheduling, which ended up being in the Halt Fentanyl Act, which passed last year. 9 years of working federally and kind of learning how things work, and just the interaction of what happens the state and federal, and trying to work at the local level, removing the barriers to giving better care. And I think SAMHSA has the with the grant funding opportunities and leading with scientific best practices and the coordination across agencies and operational divisions. I think there's a unique opportunity with MAHA, and I really see a mission as looking at what can we do to kind of drive the culture away from being a pill culture, and how do we create cultural change to look at health from a well-being perspective of eating and exercising and staying connected with our loved ones, and interconnectedness. And I feel like, again, Dr. Ganjotra, the CMO of SAMHSA, can speak to a little more with some of the technical pieces of it. But that's what I see, the vision that I have for SAMHSA is really looking to restore emotional, mental health and substance abuse treatment patterns in the country.
Thank you, Dr. Westlake. I'm Jim Gandotra. I'm Chief Medical Officer here at SAMHSA. I'm an addiction psychiatrist. I can say, as Dr. Westlake has mentioned, we do service delivery grants, we do training and technical assistance. That's certainly where we're trying to lean into when it comes to addressing the strategy related to the MAHA report. And we are certainly deeply honored to be selected to help lead that strategy when it comes to examining prescribing practices for SSRIs, determining which policy levers and resources could be marshaled towards addressing the problems related to the mental health crisis. And in particular, the role that we're having is that we're bringing all of our agencies together within HHS. I would say that while SAMHSA's honored to lead that working group, it is truly a group effort with NIMH, FDA, ACF, the Office of the Assistant Secretary, the Internal Office of the Immediate Office of the Secretary, HRSA, CMS. We have full representation across HHS in terms of the working group. Each one brings their own perspective. We're trying to have not only those perspectives align with the MAHA report, but also have a consolidated effort over a sustained period of time to not only understand the prescribing practices, but ultimately come up with recommendations that will be long-standing and impactful. And that's the real key, is to understand that, this didn't happen overnight. So we have to address it in a way that is truly aligned with the MAHA strategy across not just this year, but across the next several years.
Thanks very much. Thank you for the opportunity to come and serve on this panel. My name is Andrea Beckel-Michener. I am the acting director for the National Institute of Mental Health at the NIH. And our institute is the leading biomedical research institute in the world investigating mental health. And we have a large portfolio, a very broad portfolio of research that ranges from basic fundamental understanding of healthy brains and healthy brain function, applying that research to understanding how to intervene and how to develop novel interventions, and that could be psychosocial, they could be pharmacologic, could be combinations, as well as understanding how some lifestyle changes may be helpful for individuals. And we finally have a third major thrust, which is in services research and the delivery of services of those interventions that work. The bottom line is we're here to build an evidence-based, build the database that will help policymakers make the best choices and help physicians and practitioners work with their patients to know how best to deliver services and what might be best for those individuals.
So good afternoon. My name is Marta Sokolowska, and I'm from FDA, from the Center for Drugs. I'm the Deputy Center Director for Substance Use and Behavioral Health. And I wanted to start by saying a big thank you to all those patients and the voices that are being raised, because it's really critical that we hear that. We hear that because that really helps us to lead the policy and really understand the risks, like the communication that maybe you have to consider. So just briefly, as FDA, our mission is to protect and promote public health by, at least within Center for Drugs, to assure that we have safe and effective medication for patients. In my role, in my position, my focus is to proactively identify and analyze emerging issues related to substance use and behavioral health, and work with my center director and other agency leadership to make sure that that information is included in our regulatory decision making. So thinking back to the MAHA report, there are a number of positions that identify potential risks related to the medication. So we are looking at the dispensing patterns, and we are even importantly really work closely with our sister agencies that are right here with me on the panel, really trying to figure out as the issues are evolving, what is the role for each of our agency to help to address this issue.
Thanks, Marta. So starting with Jim and Tim, our understanding is that, as you mentioned, SAMHSA has really taken the lead in implementing some of this cross-agency collaboration. And SAMHSA itself has so many tools in its toolkit. So could you give us an overview of what resources, best practice guidelines, financial supports that SAMHSA does or could provide to the medical practitioners, to individuals, to try and promote the safe tapering and discontinuation of psychotropic medications that we've heard about throughout the day?
Thank you for the question. Certainly, we know that overprescribing is an issue now. As everyone here knows, to get that out to the nation, to get that out to prescribers, that information is the first step, disseminating that. And our working group is certainly evaluating claims data, we're evaluating pharmacy dispensing data, and ultimately we're looking to create products that will be able to disseminate that information to prescribers and to patients so that they're aware of the prescribing trends. And certainly that's going to come in the form of either a document like a report, a fact sheet. Those things are already in process. Certainly we want to ensure that not only do providers have the information of those trends, but being aware and armed with that information, patients can also take a more active role in understanding that, this is not just a strategy that we have developed out of whole cloth. We know that if we educate folks, it's going to change behavior. We saw that with smoking. In particular, tobacco use has certainly gone down as we educated youth on the risks related to tobacco. In the same way, we educate patients about how prescribing has really not necessarily the first choice that's needed in many situations, or at least when it's clinically indicated, it's a shared decision between the prescriber and the patient. The other thing that we really have to understand is that with screening and diagnosis, while that is important, I think the previous panels have highlighted that it has to have the right context and the right tools that need to be addressed. If we're going to implement an intervention, we have to be able to have the right treatments available afterwards. The right consequences to that intervention need to be in place. So while medications are an important tool, it's important to recognize that, as Tim mentioned before, there's two groups, those who are already on the medications and those who may be screened and might be potential candidates. Certainly we want to utilize judicious prescribing for those who have not yet started. For those who are already on, it's really important that clinical practice indicates that there is either at some regular interval reevaluation of the effectiveness, but also the idea that those who are on it have patient autonomy when it comes to coming off of the medications. And what that's really going to take is educating providers, reminding them not just about patient autonomy, but giving them information about deprescribing. And that's one of the charges of our working group, is to figure out how can we go about doing that. And certainly, first we have to understand the trends, and then we have to look at the data and look at the research about deprescribing. And we will be working on that too. That'll probably be part of a little bit more later in the discussion, but we are going to provide resources across the federal government for deprescribing, in addition to a number of other items that we'll be able to point to say this is something that prescribers can use, this is something patients can use, and this is something states and territories that receive our grants can use. I'll highlight one last thing, and that is our funding announcements do indicate that now deprescribing is an allowable activity. Training on deprescribing is now allowable activity for our grants. So we're putting money behind this. This is now something that we're able to
I'll take over in asking a couple of questions here now, and to Dr. Sokolovska from the FDA, and I think you were in the room when Dr. Horowitz from the UK sort of listed, one of the most complete lists of change proposals, remedies, operational and so forth at different agency levels that could be done. And so I'm wondering, and I know the FDA has done recently, you did recent work yourself, you participated in this on benzodiazepine warning labels, tapering guidelines, and I'm wondering what it would take to do the same for the SSRIs, for example. What would it take for an agency like the FDA to produce what you did for benzodiazepines for SSRIs?
So I think it's really important to highlight the importance that the benzodiazepine guidelines or our HHS opioid guidelines, they all started with stakeholder output and really outcry from, or the input from the clinicians and patients regarding the unmet need, which was the tapering that was not well guided. And that's essentially, it was the call that we answered as a federal agency. And I'd like to start with opiates because actually it was one of the first actions that I did as part of a federal agency as after I joined FDA, working across CDC, SAMHSA, NIH. We put together essentially HHS guide for clinicians on the appropriate dosage reduction or discontinuation of long-term opioid analgesics. We are really good with long names. Can't you tell that I have to write it down? We issued in 2019 because, again, we've heard over and over again about the unmet need, about patients who are struggling or being dropped sometimes from care, or clinicians, they were not well informed how to taper patients. When there was a shared decision-making, we emphasized the importance of shared decision-making. And when there was reach, how to get to the tapering effort. And as we were working on it, we recognized that opiates are frequently prescribed with benzodiazepines. So we updated the benzodiazepine labels as well. And as we are engaging with the stakeholders, guess what? We've heard again that there are guidelines in Europe and UK regarding benzodiazepine tapering, but our clinicians were struggling to figure out how to approach it better. So in that situation, FDA is actually typically we are not regulating practice of medicine. That's important to highlight. So we issued a NOFO, which is funding opportunity announcement, that we were seeking to award organization that would be willing to actually use the evidence to draft clinical practice guidelines for the prescribing of benzodiazepines. And ASAM, American Academy of American Society of Addiction Medicine, won the award, and they worked together with 10 organizations to put together their guidelines. They issued the draft guidelines. We got a lot of comments. And the final guidance was just issued last year, and together with SAMHSA, we issued joint announcement further emphasizing the importance of it, the importance of the shared decision-making, and making sure that a lot of clinicians were aware of this activity. And I just came back from ASAM last weekend, and guess what? They had a whole session on the prescribing of benzodiazepine using the guidelines that we funded. So I think it's a really great example that when there is a need, their action follows.
Thank you for that. I just have my follow-up question is what is the level of need that's necessary when you talk about stakeholders? Is there, I mean, what was the need expressed in this room? Does that need to be multiplied 10 times by different kinds of stakeholders? Is that what will grab the attention so that there's more activity, or for the SSRIs, for example?
As it was already mentioned, we are already discussing across the agencies the importance of it and potential actions how we can address it. And there are different ways we can do it, but the need is already recognized.
Thank you. Dr. Beckel-Michener, you rightly emphasized in your introduction that you lead the world's largest, really, agency, I guess, governmental agency for funding mental health research. It's amazing that we have that agency in the U.S. And in 2017, after leaving the NIMH, former director Thomas Insel made this comment that, had a lot of traction, and I'm just quoting a sentence or two. He said, "I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders. And when I look back on that, I realize that while I think I succeeded in getting lots of really cool papers published by cool scientists at fairly large costs, I think 20 billion, I don't think we move the needle in reducing suicide, reducing hospitalizations, improving recovery for the tens of millions of people who have mental illness." And in 2025, there was a paper in Ethical Human Psychology and Psychiatry that estimated that in 2020, the NIMH spent about 75% of its research funding on physiology, genetics, neuroscience, compared to 4% on psychotherapy. And so I'm just wondering, has the NIMH begun to think about modifying its funding priorities to better understand maybe environmental, psychosocial, behavioral determinants of health and well-being?
Well, yeah, thank you for that question, and thank you for referring to that paper, which I had not seen. So it was really important for me to read that paper. Can I just respond to your previous question just really quickly before I answer that one? I just want the room to know also that in building the evidence for deprescribing of SSRIs, the NIMH is always a home for research studies on this topic as well. So most of our grant applications come in as unsolicited, investigator-initiated grant applications that go through a review process, and then we look for the most important questions. This has obviously been established as a very important question, and the most compelling research studies, and those awards will be considered for funding at the NIMH. So I want to make sure that this audience does know that. So in response to your question, David, I looked at the methodology. I am not going to talk about methodology, or I will have 95% of the audience asleep. But we did look to try to replicate that study using our methods within NIH. We have a system called Research Condition and Disease Categories, RCDC, and a very highly engaged reports and analysis branch. So they looked at these categories that are available publicly, and they actually narrowed down the search for behavioral and social science, dissemination and implementation research, and health services research. These are all categories outside of neuroscience and genetics and some of the fundamental studies that we continue to support about healthy brain function. And then also use the sort of a filter for applied research, which really helped us look at all of the grants that we have funded in the last 5 years. And what we found using that methodology and that analysis is it was about a third, in that, I want to make sure I get these categories right, relates to behavioral and social science, dissemination and implementation research, and health services research. I think I said that. And we had about a third, 30%, 34%, 33% across those categories. So I would be intrigued, and I have not had enough time to really look at the differences of the methodology that you provided to me and some of the work that our internal team had investigated. But this is a really important part of the portfolio. So I do think that, as I mentioned earlier, we do invest in lots of different categories. I think the main point for our research portfolio is things that will give patients options. Whether that is pharmacological intervention, psychosocial, or again, some of the health behaviors, the health lifestyle changes that can be very helpful for a lot of people, or combinations. Much of the research that we support, this is also hard to measure because there's often combination approaches in the research projects, but I think for many patients it's often a combination or sequencing those interventions in important ways and knowing what is best for a patient. You've seen one patient with depression. You've seen one patient with depression. So some of the precision psychiatry that we are looking to support. Some of this does go back to the fundamental studies that Dr. Insel may have referred to in the quote. I think many of those are actually looking to the future. One of the things that we observe is that we support studies now that are more proximal that can help patients now. We also have sort of intermediate studies that look to improve our interventions and the evidence-based for things that will probably be 10 or 15 years down the line. And some of these other approaches are really looking into the future. What can our children and grandchildren who become scientists and doctors apply for their patients? And so it really is looking at both the breadth of the portfolio as well as looking into the future for what might be best for patients.
Thank you.
Back to Tim and Jim. So SAMHSA is involved in a lot of recovery-oriented behavioral health care. And Tim, I know based on your experience, you have a lot of intimate experience both in your practice and at the state level dealing with addiction and behavioral health care. So can you tell us more about the initiatives, grant programs that SAMHSA is pursuing or could to counteract overmedicalization and specifically the prescribe first, the pill culture that you've described so well, as well as testing and promoting non-pharmacological or integrated approaches, and hopefully with the goal of allowing more Americans to live pharmaceutical-free futures.
So I think the kind of the overarching, question is again, what can SAMHSA do and the support and the levers that we have so that we can, best help create a culture that looks at the prescribing, as far as are we prescribing what we should be prescribing? Are the patients getting the appropriate treatment that they get? We're looking at things when it comes to recovery, which kind of tie into this mirrors the opioid epidemic that we had, 12 years ago, almost exactly. And looking at the changes that were necessary, the changes from within the medical system, and again, not just from the top down, but from the medical community itself coming up through. And so driving the changes that Dr. Gandotra was talking about as far as best practices, that's key. Looking at making sure that there are funding opportunities to studying the outcomes of programs. Do those programs, not just is it a program that starts, but is it a program that results in the outcome that you're looking to measure.
Thank you, Dr. Westlake. And certainly there's a lot that we're working on, and there's two things that I think are really worth mentioning. Education and training is one aspect that we certainly are going to lean into. I'll certainly announce that we have two webinars that are specifically designed for providers and as well as administrators and patients as well, but really to talk about getting this education out there. We have two webinars scheduled for this summer. I believe our own Laura Delano is going to be speaking at one of those, as well as experts in deprescribing are going to be providing information on, I believe, June 3rd and July 16th. That's a two-part series on deprescribing. That's something that we're going to lean into with regard to prescribers. We'll be providing educational credits. We're really happy to do that first. We're also working and knowing that primary care is one of the areas that really initiates a lot of the prescribing. We're going to have a joint webinar with our colleagues at HRSA, really focusing on the FQHCs and prescribing, and the idea that we're going to promote non-pharmacological interventions currently so that patients have the ability to have fully informed consent. That's the bottom line. Is that but we know education only goes so far. We can do a few webinars now. We'll certainly sustain those efforts in the upcoming years. We're certainly going to track the data with our own resources as well as those partnerships. I think it's worth mentioning ASPE also has been a great partner in evaluation, and in particular they've committed to looking at this data longitudinally over years, so it will inform our decisions with regard to future educational programming. And then the bottom line, as Dr. Westlake mentioned, is we've put our money into this as well when it comes to our grants now, not only having allowable activities for tapering, but also training for the tapering as well. that's something that, we're really leaning into in terms of education and money. Thank you.
Well, it's great to hear that, and hopefully, an entity as large as the federal government, this paradigm shift is an enormous task, and hopefully, with your top-down effort and our grassroots effort, we can meet in the middle and see some success pretty quickly. For MARTA, we've heard throughout the day growing concern and advocacy about all sorts of adverse effects, including post-SSRI sexual dysfunction, physiological dependence, withdrawal, risk associated with taking these drugs during pregnancy, and many other adverse effects. So does the FDA believe that the current boxed warnings on these medications adequately reflect the risk of these harms? And what would be the process and threshold of evidence required to update these labels as you have in the past?
So thank you again for the question. I think it's important to highlight that FDA is reviewing safety and efficacy for medication, particularly safety throughout the life cycle of a drug. So even though bulk of our work occurs before the drug approval, after approval we continue tracking safety signals for the drugs. And once we are recognizing that there are potential additional risks, we collect information, we evaluate the information, and make changes as appropriate. If you think about opioid labels, we revised them on a number of occasions, including one just last year. Regarding this specific issue, I just want to highlight that we currently have about 5 citizens petitions requesting revision or alluding to some of the changes, some of the risks that you have identified. All but one was submitted last year or this year. So we are currently, as per our process, as we would do with any medication, we are evaluating the citizens' petitions and the data that was submitted with the citizen petition. We are, in addition to it, we are collecting other information that is in public literature and within our databases to make sure that we have as comprehensive information as we can. And once the analysis is completed, we'll make a decision if additional changes are required.
And would that occur through a public notice rulemaking, or can the FDA do that within its own authority?
No, it's done automatically through, if there is a need for safety need for label update, we will issue such an update, or we will inform the sponsors that they need to update the label, and likely to be associated also with drug safety communication if it's appropriate.
Thank you.
I have another question for Andrea, if I may. So we've heard talk of figures of 60 million Americans taking psychiatric medications. We've heard a figure quoted of the median amount of time people are on a medication is 5 years or 8 years. I forget the exact number. I've heard more. So, and the NIMH has been studying the brain for decades. And sometimes, besides unsolicited research that you get or research requests, do you have a plan or a more structured plan to study the effects of decades of medication on the brain? People who are on medication for a very long time, how does that affect the brain, and how to help people come off medications as we've been discussing today?
Yeah, so I think that we have done some work in this in the past. For example, this isn't exactly what the question is asking, but there was quite a large study, I want to say 15, maybe more years ago, called STAR-D, Sequenced Treatment Alternatives to Relieve Depression. If you probably remember that, David. This was actually looking at following patients with depression across multiple treatment steps and how much to increase medication doses or change to other treatments. This was not specifically designed as a tapering study, as you know, but it really generated important information and data about treatment sequencing, remission of symptoms, and what happens when patients stop or switch medications. And that was probably one of the largest data finds that we had. I think we can possibly do something similar, but with specifically targeting tapering as an outcome and monitoring not just the mental health outcomes, but also potentially other markers, physiological markers for those individuals. You know, there's a lot of challenges here, as I know we've discussed throughout the day. What are side effects of the medication? what are withdrawal symptoms from the medication, what might be reemergence of symptoms of the condition, assuming it was diagnosed in the right way in the first place. We heard a lot about that as well. So I think the answer to your question is there are myriad research opportunities. We typically don't discuss publicly when we are trying to look for what those funding opportunities might look like, but I can assure you and this audience that the conversation is strong inside the Institute, and we are looking at our partner agencies to better understand how we can support these investigations.
Thank you.
So the title of this panel was a coordinated path forward. So we've gotten a little bit of insight into what each of your agencies is doing internally. But from an external point of view, from the average citizen, it can appear that the work of all these agencies can be a little bit siloed, especially in the federal government as big as it is, and HHS being one of the largest agencies in the federal government. And you might have noticed this yourself, and might even be a little frustrated with some of those walls. So what is one way that you think your own agency could work together with the other two in service of the broader agenda that was outlined in the MAHA strategy report of reducing over-medicalization and potential harms?
Thanks for the question, Justin. That's a great question. I think just the example of having the NIH and the FDA and SAMHSA here together already working together is already proof that there's something different that's going on here. It's not just siloed, different, programs that are getting popped out by each different division. And there's really an attempt to collaborate. This is what I really want to bring to SAMHSA. Is the ED experiences that I had, when I was resuscitating someone on a cardiac arrest, and the nurse would say, what do you think about this? And it was the team approach of, everyone's got their own lane and everyone is doing things in their own space, but when we work together, it's where the real power comes from, and that power that I see from collaboration. I mean, I really see this as a seed change to, what the MAHA movement brings to looking at, food as medicine, and how should we really treat disease? It really just shouldn't all be about treatment. It should be about prevention, and really, what can get us to move away from a pill culture. Those are things that really kind of excite me and drive me, and seeing the way that the federal government is coming together and the movement is starting. I mean, it's exciting. I think this is how this is the beginning of how things change. It's not going to change in a year. It's not going to change in 2 years, but this is how we change the culture and get things to be so that people can be healthy.
Thank you, Dr. Westlake, and thank you for the question. I would really point to the formation of this working group. We have representation across HHS. We correspond weekly. We meet biweekly. We strategize on how we can address this problem. I can say it's taken a whole of government approach, at least within HHS, to understand where we have shared alignment and also where we can collaborate. I've already mentioned the webinar we'll be doing with HRSA, focusing on FQHCs. Certainly we collaborate with FDA and NIMH on a regular basis. I can say that members of the working group now, we are corresponding every week, and we're reviewing things, bouncing things off of each other, trying to really collaborate on this shared goal.
Yeah, reiterating that comment that Jim just made, and a member of that working group is also here in the audience from NIMH, Dr. Matt Rudolfer. And I think one of the things that we're seeing is each of the agencies brings a slightly different focus, a slightly different lens to the question, and working in collaboration and building on those strengths that each agency has, and finding gaps that maybe we had not yet identified previously. So that really is the power of the partnership. This is one specific area. We could name lots of different areas that we also have collaborated on and continue to collaborate. But for this purpose, I think that this is going to be a real sea change in our understanding of this problem.
How do I follow that? But just wanted to add that, each of us, as much as we are working extensively across, and we spend a lot of hours on team calls, it's important that each of our group has somewhat different lens And even within FDA, I'm in the Center for Drugs, but there's a Center for Devices. And, and many of us have some version of devices on us. It's another opportunity. We need to understand the patients where they are and how they are engaging. And actually, that's why each of our group has somewhat different lens they can bring to their discussion that can help to really make sure that we don't focus on the agency first, but the patient first, and we try to understand the patients and help the patients and the clinicians from our different vantage points. And I think that's what we are trying to do as much as we can.
Well, thank you, Marta. Before I let David answer to his last question, if anyone in the audience has questions, if you could please write them down on some of the notepads we have, and our MAHA Institute volunteers will pick them up and bring them up to the stage for that last Q&A section.
Okay, and so this is a final question again for all of you, and the last one you answered was about cross-agency reforms, and this one is really in the service of that broader mandate of how do we address the over-medicalization crisis that has been discussed today. What is one reform that you wish to implement or might wish to implement, if you can say so publicly? We could start with you, Marta.
Thank you. I don't know if it's reform, but one thing that I think would be really helpful is to make sure that we have more targeted data that would help us to make the regulatory decision making. Because I hear a lot of passion in this room, and it's really important. It gives me a reason to work on a lot of these issues, but at the end of the day, we really need the data that will help to support it. So that's why I would ask for more data and more studies on the specific issues to help us to understand how we can help patients and meet patients where they are.
I'm going to riff on that because I think it's a great comment. I think if there was one, if I had a wish, one thing would be this precision psychiatry initiative. We've heard a lot about the ambiguity and the heterogeneity in diagnosis, and I think some of the things that we're supporting, the studies that we're supporting, that help look at precision diagnostics and biomarker development, as well as some of the behavioral outcomes that we try to measure, that will give patients more treatment options. Marta mentioned devices. We also have a portfolio on devices, and those are really for the treatment-resistant forms of depression. And we're seeing some success, and we're also learning more about what the brain is doing in those situations. So I feel like that precision psychiatry initiative, if that were to be a dream realized, I think it would be a game changer.
Thank you. Jim?
Well, I agree with both of those. Certainly, the data always stands to be improved, but certainly we have significant gaps, and certainly our working group is identifying. I will say on a couple positive things, certainly the work that all of you are doing and strategic partnerships we hope to develop are really going to be the key. I think that's one area. I wouldn't even call it a wish. I think we're doing it today. We're certainly going to foster further investments. The other part is through our continued work, not only collecting the data, but also being responsive quickly to those data trends is going to be key when it comes to developing policy, shifting our grant focus, all of those things. I think we've made tremendous progress, and certainly we see a lot of things to be hopeful for as well.
Yeah, I don't know that I have actually much more to add than that. I think that, just the collaboration, and that's what I'm committed to, is collaboration across agencies, not just making this, we're working well together and then going back to the silos. I think to really drive that home. And then I think to build a structure and a framework that, we're able to help, deliver the best, possible medication, not medication, but treatment for our patients and, and bring health back.
All right, thank you. So we'll just jump into some audience questions here. This is for Marta. So it's great to hear that stakeholder input can often drive FDA's actions. But why is it that it can sometimes take a patient submission to draw attention to a serious issue regarding, in this case, dependence and withdrawal? Does that mean that there's some system within the FDA that is not necessarily fit for purpose, especially issues like we saw with benzos and opioids?
Again, it all goes back to the data sources and how the signals are being identified, right? So if there is not sufficient data, then we have to figure out how do we collect the data, and that's where patients' notice are so important. So we can actually, once we get the identification that it's something that we need to address, we can look into more broadly, and that's why we are looking at the citizens' petitions, for instance, and other sources to hear from the community where else is needed for us to address it.
Okay. Now we have questions from the press. This is from Politico. How exactly is SAMHSA aligning its NOFOs, Notice of Funding Opportunities, with the priority to decrease overprescribing?
So we've added, thank you. We've added standardized language to relevant NOFOs that allow for deprescribing, training, and more importantly, those allocated resources are going to be continuous over multiple grants, multiple years. But in essence, we're specifying standardized language in our funding announcements to allow for deprescribing practices, training for providers, and really ensuring that patients will be able to have those periodic evaluations throughout their treatment course.
Next question. The problem with safety signals is that clinicians are not recognizing the harms. For example, no limbs with thalidomide is an easy example. How does FDA take into account that the withdrawal of antidepressants often looks similar to the symptoms of the underlying problem? It says here clinicians don't necessarily, can't repeat what they don't understand.
I guess the question is for me.
Yeah, sorry.
I just want to say so that is the reason why we need more studies to better understand and dissociate these two aspects. Because without it, it is difficult for clinicians and it is difficult for FDA to differentiate those two. So that's why it's so great that we do have an IMH also at this table to make sure that we can collect the data and address it together.
All right, and this could be for anyone. Clinical guidelines are written by doctors with financial conflicts of interest. What can be done to prevent this in the future?
Well, I think transparency in the process is going to be key. Bringing forward not only experts but those with lived experience, those with shared interests in achieving a common goal, keeping everyone relatively honest with regard to that. There are going to be potential conflicts of interest that can be mitigated with honest discussion, looking at not just the data, but what's best for the patient and what's best for the country. I think keeping that principle, we learned very early in medical school, you stand on patient care, you really don't go wrong. And that's how we're going to navigate that those conflicts as well.
Anyone else? Okay. Here we have another press question. You've listed what the agencies can do, but what would you want to see Congress do in this area? If you had a magic wand and you could have Congress do anything.
No comment.
That's the toughest one of the day.
More funding for research?
Yeah, I think that's the main opportunity. So looking from the state perspective, when we was looking at what legislation is useful, I think when you're a legislator, there's a lot of things that look like it can be fixed with a legislative fix, but I don't know that in healthcare, that the healthcare regulation is done at the state level. The federal government provides the resources for, studying, finding, doing the research, setting, what are the best practices. But there's no simple law that's going to fix this. This is a cultural change that is happening and needs to continue to happen. And we need to be careful with what we do legislatively. You got to look back to the opioid prescribing epidemic that happened and what were the causes of that. And we need to be, well-intentioned, but we need to be very cautious with the, I look at it like we need to do like legislative and regulatory jujitsu, where we just apply the most limited amount of force or leverage to get the outcome that we want.
And we have another question here from Ellen Berry, New York Times. 1 in 6 Americans takes an SSRI. Is that too many? What should patients take away from what we've heard today?
So I can, let me just jump in with some other numbers. So approximately 40% of individuals who are, first of all, SSRIs, if they're prescribed appropriately for the right patients, can be very safe and effective. And 40% of patients who are prescribed SSRIs do very well on them, and they can be life-saving for many. But that leaves an awful lot of people who do not do well on SSRIs, and that is where we need to do more research, and doctors and providers need to have better options and further discussions with their patients in order to make sure that the treatment options are there that suit the patient, that will help them get well.
I'm going to add to that. I think also that it's very important with every treatment that we use in medicine that we continue to reevaluate whether the treatment that we give is helping and necessary to continue. And sometimes it is, and sometimes it isn't. But we need to be careful of just putting people on stuff and then losing track of it. And that's where I think just the re-education process of, okay, you're on this, is it helping, is it benefiting you? Great. If it is, okay. If it's not, then what's the plan to take you off of it? And in the beginning, should you even be on it in the first place? And I don't know, it's a complicated question, but we need to just go back to the fundamental principles of doing what's right for our patients, like Dr. Gandotra said.
Let me jump in for one last thing, and that is that maybe it's the last thing, maybe there will be other comments, but that the take-home message also is that there are options. If the only tool in the toolbox is medication, so that's the only tool and it's a hammer, then everything looks like a nail, and that's the only thing that is going to be applied. But there's so many other tools that could be applied, and patients have options. They need to be aware of those options when the decision for medication is being made. And then, patient autonomy is certainly going to be the principle that overrides the rest.
If I can just add something to it. Shared decision-making is something that FDA has been, and not only FDA, the number of agencies on this panel have been advocating for together as we are trying to approach this issue across the different drug classes. But I think that and I understand that we have federal panel, but I think to really address the question, we are really missing representation of medical societies, because they really represent a lot of groups. They know what happens with boots on the ground, and we really need to have them at the table to help us to understand some of the issues and challenges that they are facing, same as we need to have patients at the table, because otherwise it's somewhat challenging, and it could be very misaligned if just federal agencies with best intentions are trying to drive the conversation. We really have to have all the stakeholders at the table and hear their comments too.
Yeah, where the rubber really meets the road is with the professional societies, the medical boards, the hospital systems. That's what's going to change prescribing practice. It's not going to be coming out, like the CDC guidelines when they came out, they were great, but that's not what changed the prescribing practices. It was the understanding that there was an issue, that the prescribing had gotten out of hand, and then there were the needs to change that happened, and that came from, like you said, within the medical community itself. And so it's very important to engage and not alienate, because as doctors, we want to help people. We want people to be healthy. We want them to heal, and that's where we all come from with that.
Here's another one for Dr. Beckel-Michener. Some of these drugs have been on the market for 30 years, and there are no studies for how to safely stop them. Shouldn't there be as many studies on how to stop drugs as there are to start them?
Yes. Let me just say that actually I was looking at some of the literature last week and over the weekend, and there are actually thousands of studies that use the word tapering for psychiatric meds, and these many of these are more recent. And then more recently, there's deprescribing is a term that's used, and so there are a number of studies that are out there. My impression is that many of these are one-offs. They look, most of them, the ones that I looked at in detail, were good studies, but it's not enough. It's sort of, again, this goes back to David's earlier comment on Dr. Insel. It's a study on the shelf. the critical feature here is how we work with our partners to help to broaden the evidence base of what deprescribing is, how we get that information out to providers and to patients, and to make sure that what is being advised and what is being discussed in that exam room is something that is based on the evidence and will help the patient ultimately.
This is for, I guess, for everyone. Diagnosis has become the price of entry for help. What changes can federal agencies make to ensure children are not required to be pathologized to access help? May have been a better question for the previous panel, but...
I think, well, did you want to answer? So if I understand the question, I want to first make sure I'm going to answer the right part of that question, which is that what are changes that could be made to ensure that, in this case, over-medicalization, that children are not given a diagnosis just to get entry?
Yeah, I think that's the gist.
So I think the idea that that a problem exists means that it needs to be addressed. But putting a label on that problem is not necessarily the cost of entry. I would somewhat challenge the idea that a child needs a label to get services. I know that in some places that's the way that things appear. But I think we focus on the problem and then the outcome. We've heard from so many panelists about how there was this difference in problems or the response, and I would think about the idea that maybe we shift away from that diagnosis being required for, and I'm going to call out payers, that we don't need a diagnosis for reimbursement. That what we need is a problem that needs to be addressed, and I think that might be a way to slowly move towards something else, but we may not be able to move directly to the next stage without addressing the problem that is being presented. It's just my 2 cents on that.
So I can answer this also as a mom. And I think this is a problem. I think that when you have kids in the system, and I know the previous panel, I'm not going to reiterate their expert opinion on this, but you have kids that are entering a system and then they do get this label, and that could be extremely challenging. One of the ways that we are addressing that from the research perspective is to look at something that Tim mentioned earlier, and that is prevention. Prevention is the best intervention. Obviously, early intervention when you do start to see problems. But I think focusing on prevention and knowing how to keep children well and how to better understand the diversity of behaviors that you would see in a kid, I think is so important. And we do support work on prevention, and I think that's a really important area that we could invest more in.
So this is sort of a follow-up, another motherhood question. From some of the discussion, it sounds like the assumption is that the medications are safe for long-term use or for pregnancy unless they are definitively proven to have any safety issues. Doesn't this violate the precautionary principle? Shouldn't a basic assumption be that these chemicals are likely to cause harm with long-term use or in pregnancy, and that if we see signals, then we must warn the public?
We need data, right? We need data for everything. So it will be important to collect data so we can demonstrate if there is a signal, because there is a benefit. If there is a benefit, we do not want to take it away from the right patient. But if there is a signal, we also have to be in a position, and we need to have the data and be able to collect the data. And now with evolution of the data and the new system being created, hopefully we'll be able to get the data quicker so we can inform patients, because it is a balancing act. And you want to make sure that safe and effective medications are provided to patients, because if they are not having the treatment, they are not in a good position. But also at the same time, we do need to make sure that as soon as the data is available, it is communicated, both through regulatory agencies as well as through others.
Sure, I'd like to ask this question. I'm not sure what it is, if that's okay. And
Sure,
maybe
please.
are we calling it?
Yeah, we'll have this be the last
I think this will be
one.
the final question.
Yeah.
But you're being very patient and very gracious in answering our questions. Governor's Challenge, I'm not sure what that is. The Michigan Governor's Challenge appears to be the only state in the country to have a subgroup focused on psychotropic drug safety. This group held an accredited CEU CME training in the state capitol in November of 2025. Does SAMHSA plan to continue the Governor's Challenge and possibly use it as a vehicle to train providers and communities nationally?
So I will say, certainly we can look into that specific CEU activity. We are going to have our own sponsored CEU activities on June 3rd and July 16th, and another one over the summer. We plan to open that up at least to thousands of providers to be able to attend. Look out for those announcements shortly.
Thank you. Thank you to Tim Westlake, Jim Gandotra, Andrea Beckel-Michener, and Martha Sokolovska. Thank you so much.
Thank you very much for your
being here
patience.
today.
Thank you.
I just want to make a quick announcement, which is that we're going to close the doors now, so we're going to take a small break where Secretary Kennedy arrives, but we're not leaving the room. Sorry, so you're locked in, locked down for just a few minutes. But we'll take a small break while we rearrange the stage for that. Thank you. Sorry that you can't.
Yes, I just got sworn in.
Sorry, I just need to make one more announcement. If everyone could just, for 1 minute or less than a minute. So when the program ends, when Secretary Kennedy wraps, we all have to remain seated until he leaves the room. So again, when Secretary Kennedy arrives and when he parts, we are not allowed to approach the stage, and we have to remain seated until he leaves when he's done. Okay, that's just a request. That's for security reasons. Thank you very much. Can you turn? Hey there, we need everyone to take their seats, please. If you could please find your way to your seat, that would be very helpful. Thank you. Can you go help and make sure people are seated?
We're waiting for Secretary Kennedy, but I appreciate the gravity of the. Okay. I now have the privilege of introducing our next speaker, United States Secretary of Health and Human Services, Robert F. Kennedy, Jr. For years, Secretary Kennedy has been a leader championing the fight against health system corruption. He has bravely spoken out against the corrupting forces that have been sickening Americans. He has stood side by side with parents of children injured by our corporate predatory medical system. He has refused to back down in the face of withering criticism and massive, well-funded slander campaigns. His courage has earned him the respect and the devotion of a large fraction of the country. During COVID, nearly all mainstream press reporting supported an official public health narrative which we now know to be false. And as the leading critic of the establishment orthodoxy, Secretary Kennedy was deplatformed, canceled, and treated as a non-person by the mainstream media. In 2023 and 2024, the mainstream press twisted its reporting to support the establishment Democratic presidential candidates. Again, Secretary Kennedy's fight to stop medical corruption was viewed through a narrow partisan lens, and the coverage of him was incredibly unfair. By allowing partisan mandates to guide its coverage, the mainstream press has found itself on the side of predatory drug companies and has horribly mistreated a courageous and honorable man. By attacking his righteous work, the press has given aid and comfort to corrupt interests, contributed to the sickening of America, and lost the trust of a large fraction of the public. If we are to reclaim our health system from the clutches of moneyed interests, we need to leave behind partisan filters and be guided by the North Star of the health of the American people. I hope that the press will recall the high aspirations of journalism, challenge the corrupt interests which have captured our health system, and do its part to heal our broken health system. And without further ado, I give you the Secretary of Health and Human Services, Robert F. Kennedy, Jr.
Thank you, everybody. And thank you for that introduction, Mark. Mark should have been speaking about himself because he was, during COVID, an island of critical thinking in a sea of conformity and consensus and orthodoxy. And on all of these subjects, I'm so grateful for what you've done with the MAHA Institute, because you brought together people again and again to talk about these critical issues for which there's always been these taboos, and we're not allowed to talk about them. And, suddenly there's people actually talking about them, and you've always been a leader, and you were critical, provided absolutely critical financial support to the CHD at a time that nobody was giving us money, and he really allowed us to grow and be fruitful. And I just want to thank you for your personal friendship with me, which is so important to me and which I treasure. And I see a lot of familiar and friendly faces here. And welcome to all of you. The issues that you've been addressing today at the MAHA Institute Summit demand action, and I'm here to take them on with you. The United States does not just face a mental health crisis, we face a dependency crisis driven by overmedicalization. The data is clear. 1 in 6 American adults takes an antidepressant. 1 in 10 children are on prescription medication for their mental health. 30% of college students report using psychiatric medications in the past year. And in nursing homes, more than half of the residents are on prescribed antidepressants. That's not a marginal issue. This is a system-level pattern. Too many patients begin treatment without a clear understanding of the risks and how long they will stay on these drugs or how to come off of them. And that's not informed consent. We are going to fix it. Today, the Department of Health and Human Services released a Dear Colleague letter issued by 4 of my HHS agencies, SAMHSA, CMS, HRSA, and ACF. It directs providers across the country to expand the use of evidence-based non-pharmacologic treatments and to strengthen informed consent and shared decision-making. We're backing that guidance with action. SAMHSA, the Substance Abuse and Mental Health Services Administration, will publish new data on prescribing trends and release guidance for clinicians and physicians. In June and July, SAMHSA will roll out national training modules on psychiatric medication risks, on tapering and deprescribing. This summer, SAMHSA and HRSA, the Health Resources and Services Administration, will train providers at more than 1,400 federally qualified health centers, community health centers across the country, which treat 39 million patients, and on how to do medically supervised tapering. So they're all going to get training on this for the first time. In July, HHS will convene a technical expert panel to develop formal clinical guidelines grounded in evidence and informed by clinicians, patients, and their families. At the same time, CMS, the Center for Medicaid and Medicare Services, is issuing billing guidance that allows clinicians to get paid for deprescribing work for the first time. Care plans. They'll be paid for care planning, for monitoring withdrawal, for coordinating treatment, and for tracking outcomes. We are aligning policy with practice. Psychiatric medications have a role in care, but we will no longer treat them as the default. We will treat them as one option, used when appropriate, with full transparency and with a clear path off when they are no longer effective. Patients must understand the benefits, the risks, and the consequences of long-term use before they start, or they continue, and when they consider stopping. Without that information, consent does not exist. Right now, gaps in data, labeling, clinical guidance deny patients and physicians the full picture. Our policies will close these gaps. When the MAHA Commission released the MAHA strategy in September, we committed to confronting overprescribing. Today, we begin to deliver on that commitment. I want to thank President Trump for his leadership, for driving this effort, and for advancing the Great American Recovery Initiative through executive action, which aligns directly with the work that we are doing today to restore health, accountability, and trust in the system. We're also confronting a basic question: what happens when treatment does not work as intended? Some patients report improvement on SSRIs. Others report emotional blunting, loss of motivation, difficulty continuing use, and suicidal ideation. Withdrawal can be severe. It can be prolonged. I made a statement, I think early on in my administration, that withdrawal from SSRIs can be more difficult than withdrawal from heroin. And the New York Times and a lot of other outlets published a response from that saying that the experts disagreed with the secretary. And we all know that whenever they say trust the experts, they got nothing. But I happen to be an actual expert on this because I was addicted to heroin for 14 years. I never wanted to be. So I was constantly getting off of it and then getting back on. And I went through cold turkey withdrawal probably over 100 times. And so I know what it's like, and it's not fun, but it is limited, it is finite in time. After 72 hours, it's over. So you just have to steel yourself for 72 bad hours. But I've watched people come off of SSRIs, and it's not even comparable. And I watched a family member get off of them after a couple of years on them, and she was suicidal literally every day. She woke up every morning and said, I don't want to live. And she said, the only reason I'm staying alive is for you guys, for the family. And that's heartbreaking to hear from a family member. And I've heard that from hundreds and hundreds of people. The same story again and again. It can be prolonged, and for many patients, it's completely unexpected. And the physicians handle this by saying, oh, this is your original symptom. Reasserting yourself, you need to get back on the SSRIs. And they get locked in a lifetime cycle that is, that for many patients is absolutely cataclysmic. This is a system failure. We're not going to ignore it. And let me be clear, if you are taking psychiatric medication, we're not telling you to stop. We're making sure that you and your clinician have the information and support to make the right decisions for you. That includes a safe, evidence-based path to tapering and discontinuation when clinically appropriate. At HHS, we are building that path. We are giving clinicians the tools to guide patient safety. We're giving patients the information to make informed choices, because an informed choice is the only choice. Nearly 48 million Americans experienced depression last year. More than 48 million struggled with substance use disorders. These are not abstract numbers. These are family members. These are individuals. These are people who other people love. That is the scale of the challenge. We are not going to solve it by defaulting to medication. We're going to solve it by strengthening prevention, expanding non-drug treatment options, and restoring clinical standards that prioritize outcome over volume. Our goal is straightforward: to reduce unnecessary dependence on medication, to improve patient outcomes, and to return control of the patients. And this is how we're going to make America healthy again. Thank you all very much. And thank you all. Thank you all.